All right, I think we'll get started here. So, good morning, everyone. Welcome to United Imaging's Satellite Symposium, where we review on the progress made through total body PET since the worldwide introduction of the uEXPLORER, the first and only total body PET CT system capable of imaging from the head to toe simultaneously. My name's Ed Leong, and I'll be the moderator for this session. Without further ado, it is my heartfelt pleasure to introduce our first guest speaker, Dr. Ramsey Badawi, Vice Chair for Research in the Department of Radiology at UC Davis Health. Dr. Badawi, along with Dr. Simon Cherry, are the prominent PET experts who spearheaded the effort with United Imaging to bring the uEXPLORER total body PET CT system into existence. They are the co-directors of the Explorer Molecular Imaging Center at UC Davis Health, which houses the very first clinically operating uEXPLORER system in the world since 2019. And most importantly, I would not be here with you all today without their training and mentorship. So with that, please join me and welcome Dr. Badawi.
Thank you so much, Ed, for that very kind introduction. So I look around and I feel a little underdressed, but I'm a physicist, so I think hopefully I can get away with it. All right, so let's get started. I'm going to talk a little bit today about total body PET and looking beyond the current traditional uses, certainly that we've been using PET for in the US. Here are my disclosures. Okay, so what's the Kool-Aid? The Kool-Aid with long axial field of view and total body PET is that you can image better, faster, with lower dose. And we can image longer and later after injection, and we have total body coverage. And there's a bunch of fairly obvious applications that drop out of that for our current practice that should be able to make our current practice better. So what else could we do, say, in cancer? And something that's not done much currently, at least in the US, is dynamic imaging. Let's see if I can get this video to work. And here what we can see is that by imaging immediately on injection with total body PET, you can now get time activity curves for all the organs in the body all at the same time. And then if you feed that information into a mathematical model, and this is a fairly simple mathematical model that describes the uptake and retention of FDG in tissue, you can then actually solve with your dynamic data, you can solve for these rate constants, and then you can make images based on these rate constants. So here's an example. This is a patient with cancer, and that's a standard SUV image that you're looking at there, and that's a pretty nice image. Only took about 5 minutes to acquire, and you get this excellent image. However, if we also acquired the dynamic data for this patient and then did this parametric imaging trick, so you can get all these different kinds of images, and if you might think of this as like with an MR scan, you have all these different sequences which then give you different kinds of contrasts. So this is kind of analogous to that a little bit. You're deriving these from the same data set. You're deriving these different images with different kinds of contrast. So Ki reflects glucose utilization. And what we're doing, that kind of is like an SUV image, but what you do is you suppress the blood pool significantly. K1 represents FDG delivery to the tissue, so it's not exactly the same as perfusion, but it's kind of related to perfusion. And then we've got the blood volume here, VB. And I'd just like to draw your attention to a couple of things here. So can you see that lesion there pointed to by the red arrow? So it's highly visible in the Ki image in the liver, but really kind of not that visible. It's kind of occult in the SUV image because you've got all that blood pool that's kind of hiding it. Here's another example here. We can see this is a brain lesion, and of course FDG in the brain is really tricky with an SUV image because the normal brain tissue takes up a lot of tissue, a lot of FDG. But here what we're looking at is delivery, and delivery significantly enhanced in the lesion in the brain, and we get contrast and we're able to see the lesion. So that's just an idea of some of the things that we might be able to do with total body PET. But that opens up other possibilities as well. So typically we're thinking of FDG, we're thinking about staging or restaging. We're trying to see what happens after therapy, and that's great and extremely useful and easy to do on a nice high-performance scanner. But there are other issues that we are interested in, and patients who get chemotherapy may also get mugger scans to look at cardiac function, because we're interested in off-target effects, because we want to know if there's any chemotoxia going on, and we want that information in order to manage our patients better. So this is a movie showing the tracer going into the heart. It's taken at 10 frames a second, and it enables you to see the individual heartbeats. So now you can get information about wall motion, for example. You can get information about ejection fraction, and that's just from an FDG scan. And if you've done a dynamic scan, you get that data for free. Processing, I should say, is not free. It is it's data-intensive process, but of course, as computers get better, that gets easier. And you can actually do gating studies as well, again, with FDG. And in fact, what you could even do is to do quantitative imaging of the myocardium itself, both glucose utilization and this perfusion-related parameter K1, which enables you then to do not just wall motion, not just ejection fraction, but also look at perfusion in the heart. And you kind of get that data for free with an FDG scan. So that's something that we hadn't really considered before as a potential opportunity that comes about from total body PET. And of course, that's just like one sort of use case, right? You can think of loads of other use cases where studying off-target effects in organs that may not necessarily have cancer in, but could be impacted by the chemotherapy. And you can get functional information on that. So I've got chemo brain here, we've got liver effects, renal effects could be interesting. One of the things you do with the dynamic imaging is you can watch the rate at which FDG is excreted. That gives you some bead on kidney function. And you can also look at vascular effects as well. What else can we do? So this is some work by Doctors Wong and candidate Wong at UC Davis. They've been looking at different ways to visualize dynamic data. And there's a poster on this, number 736, that I invite you to go and check out. But check out this movie here. So the image on the left is a conventional dynamic image. The next image along, it says FDG in blood. That's basically the FDG concentration in the blood itself. The third image there is FDG that has gone from the blood into the tissue but has not been metabolized. And then the fourth image, the image on the right, that shows the FDG getting metabolized in the tissue. So I'm going to show that movie one more time so you can get some idea about it. You can see how you're getting different information of the FDG in the different compartments. This isn't something that's sort of been done before. I'm not 100% sure what it's useful for yet. We kind of think it's really cool, at least. But we're hopeful that in the future we'll find applications for this kind of technique, which, again, totally impossible unless you've got total body PET. So to summarize then, total body PET cancer, you can certainly improve current paradigms. So better, faster or lower dose. You've got opportunities to improve lesion contrast through parametric imaging. And then we've got these new biomarkers that are coming along that allow you to characterize lesions and measure lesion response, and new ways to measure off-target effects and chemotoxia. So moving on to immunology and infectious diseases, I'll talk a little bit about some work that we've been doing in collaboration with Imaginab, using a mini-body that sticks to activated CD8 T cells, which are highly implicated in a range of immune processes. So this doesn't necessarily have to be done on total body PET. This is an image on a conventional PET scanner that was published in the JNM. So that's a 3 millicurie injection roughly. And the image quality is really kind of only so-so. Same tracer on total body PET. And now the increased sensitivity of total body PET really comes to play. So it's a zirconium-labeled tracer. You can't really inject very much. 110 megabecquerels is actually quite a substantial dose to the subject, actually kind of more than you really want to be giving for an imaging test. We can do that down to 22 megabecquerels. The dose then is really not that different to an FDG image, and yet you can get these extraordinarily detailed images. You can see all the lymph nodes here from this tracer. And in fact, the image quality is so good that you can then do that other trick that you're allowed to do with total body PET, which is dynamic imaging. And I think before the advent of total body PET, this would have been unthinkable. The idea that you could attempt to do dynamic imaging with a zirconium-labeled antibody. It's just not on the cards. But once you have data like this, you can then do parametric imaging. And this is an area of open research here. We're still developing the techniques and refining the methods, but we think that PATLAC KI here, that reflects CD8 T cell mass. And we can see on these KI images, significant difference between a patient recovering from COVID and a patient who's not had COVID. And then this now allows you to do a whole bunch of other things. We can detect these low levels of tracer activity and obtain really quite remarkable image quality, I think. The ability to do high temporal resolution imaging with these zirconium tracers allows you again to do the parametric imaging I just discussed. And you can also look at migration. This is one of the things we've seen, imaging patients at 2 days. You could potentially image patients quite a lot later, and you can watch those labeled CD8 T cells migrating from one organ to another. And I think the application space there is pretty big. So infection obviously is one. You saw the COVID-19 example. But there's wide applications in cancer immunotherapy as well. Autoimmune disease, I think, is a very interesting area where this kind of technique could be applied. And there are others that would come to mind if we spend some time thinking about it. Moving on, I'm not quite sure how much time I've got left. Okay, so arthritis and musculoskeletal diseases is another area where we really, really like total body PET. So what this enables us to do is a whole body survey of every joint in the body at high resolution with excellent image quality. And potentially, we're also working on doing kinetic modeling and doing parametric imaging, again, of all the joints in the body at the same time. And again, to do that, you have to have a 2-meter scanner. You have to have a total body PET scanner to do that kind of technique. So we've got 3 examples here of psoriatic arthritis, rheumatoid arthritis, and osteoarthritis. And if you're familiar with these diseases, you can see the sort of bellwether signs of these 3 different diseases given to you by the locations of the inflammation. And again, this is just showing how it is that you can see these really tiny joints and really tiny foci of inflammation with this highly sensitive scanner. Again, this is opening up new doors for us in diagnosis and patient management. So to summarize that, we can image the characterized disease burden across the whole body. We can monitor response to therapy. And then the other thing is, those images were taken just with 2 millicuries of injected dose. You could probably go lower and still get images of high enough quality. This now allows you to do longitudinal studies on these patients who are obviously not terminally sick. They've got arthritis, they've got a chronic disease, they're not terminally ill. You have to watch for the radiation burden. But at those kind of doses, you can just keep scanning them and it's perfectly fine. Okay, what about liver disease? So this is a big deal, liver disease. A lot of people have liver disease, certainly in the Western world. So one of the issues there is with non-alcoholic fatty liver disease is that there's a sort of progression as we go from fatty liver to inflamed liver to fibrotic liver. And fibrotic liver is difficult to treat. You can detect it with MRI, but it's difficult to treat. There's a window at the inflamed liver stage, where there are a stable of new drugs that are coming online that would allow us actually to treat inflamed liver. How do you diagnose an inflamed liver? Right now, the only gold standard way to do that is with biopsy. But we're talking about millions of people. Biopsy is just not feasible to do it on all those patients. So we really do need non-invasive ways to determine liver inflammation. And again, Dr. Wong's team has been working on this, and they've got a talk about this tomorrow at 8 o'clock in the PET data management and analysis session. And these are some images showing not SUV and not KI either, so not glucose utilization, but glucose delivery to the liver parenchyma. And what we see is there's an inverse correlation between the rate of FDG delivery to the tissue and the inflammation score. And this was, in this cohort, they did get biopsies, so we're pretty sure that this is right. And that allows us, by using parametric imaging, which again is significantly enabled with total body PET, it allows us then potentially to do a non-invasive way to characterize fatty liver disease. And like I say, that's a big deal. We've got 10 million people in the US with this disease right now. And that is an unmet need of how to diagnose those patients. Okay, so I'm not really going to spend a lot of time on vascular diseases because I know Dr. Shi has some tremendous cases to show us. But I did just want to mention that this is another thing that you can do with total body PET. And also to talk a little bit about some of the work that we've been doing with carbon-11 butanol which turns out to be a really great perfusion tracer. So this is a sort of back to the future kind of thing. This tracer first showed up in the early 90s, late 80s and early 90s, really for brain scanning. And it turns out that, let's just go back a second, what's going on there? There we go. It turns out that the uptake of butanol is highly linear with perfusion. In fact, remarkably, it's actually more linear even than O15 water is, certainly more linear than ammonia, and rubidium is so bad when it comes to that I haven't even plotted it. But yeah, it's a really, really linear tracer, which then allows you perhaps to look at the whole body, which there is obviously a big range of perfusion rates across the whole body, and to do that now quantitatively. So we've had the first few goes at this now. Dr. Lee, who was Simon's student, worked hard on this. And we do, in fact, now have total body parametric images showing perfusion in every organ at the same time. So what are our opportunities? Well, high-quality imaging, assessment of the vessel walls, imaging of vascular abnormalities, and then quantitative perfusion across the whole body. And there are applications there in cardiovascular diseases. We're kind of interested also in diseases of the peripheral vasculature. Maybe also transplant as well, actually. Perfusion of the transplanted organ is extremely important. And cancer, of course, looking at perfusion and comparing that to metabolism is a potentially interesting biomarker. So I'm just going to finish up there to summarize. Total body PET-CT enables improved performance for existing imaging approaches. It allows new imaging biomarkers through highly accurate quantitative parametric imaging. It gives us tools for imaging new populations of patients at these low doses. And then finally, I didn't really have a lot of slides on this, but it also allows us to do a systems approach to imaging of disease and human biology. And here are my acknowledgements, and thank you very much.
Thank you, Dr. Badawi. Next, it's my great honor to introduce Dr. Hongcheng Shi, President-elect of the Chinese Society of Nuclear Medicine. Dr. Shi is the pioneer who directed the very first total body PET-CT imaging study in the world using the uEXPLORER system. He is also the chief physician and director of the Department of Nuclear Medicine at Zhongshan Hospital, where his team has now imaged more than 23,000 patients and has published over 30 peer-reviewed publications focusing on the clinical applications of total body PET in world-class journals, including the Journal of Nuclear Medicine and the European Journal of Nuclear Medicine and Molecular Imaging. And with that, please welcome Dr. Shi.
Thank you for the introduction. Good morning, everyone. It's a great honor to have this opportunity. And total body PET-CT has been used in clinical more than 4 years. And what's the key role? It's not definitely give the answer. So everything is exploring. So supporting evidence, that's very important. So what can we get more evidence? That's very important. So in the past 3 years, we have accumulated more than 23,000 patient examinations, including 3,000 dynamic studies and more than 5,000 low-dose studies. So for our initial experience is that so many advantages of the total body PET-CT. I think it proves that it's the clinical applications. Firstly, is that 194 centimeter long AFOV has unique advantages. For example, this is a young female that is suspected of the inflammation disease. So this patient performed the total body PET-CT scan. And we got this imaging, we can find that in the right here have this soft tissue that the FDG avid here. So just according to these areas that the abnormal, we can give that probably it's the infection disease. But the total body PET imaging demonstrated that the ascending aortic wall thickening and with the abnormal FDG uptake here. And also at the small branch here, also have the FDG avid. So finally, we can give that another diagnosis for this recent disease, that's the Katayasu arthritis. Although that's the same, that's also called it that's the inflammation disease, but that the soft tissue infection and the arthritis, the Takayasu, the disease that's totally different. So finally the patient got the system treatment and got the good results. So I think that the total body PET could help us find the key factor accurately in the view of the total body. We can think something just focus on the whole body. Another advantage of the total body PET-CT, that's the higher sensitivity. And we have, this is one of our study. We just let the patient inject the regular dose FDG, and then firstly perform the conventional PET-CT. And then after the conventional PET-CT examination, let the patient perform that the total body PET-CT with the 5 minutes aggregation. And then we rebuild the imaging in the 1, 2, 3, 4, 5 minutes imaging. Just to compare that with the conventional PET imaging, and at the 2 minutes total body imaging, we can see these lesions very clearly. So we always think that usually we will lose some lesions using the conventional PET-CT. I think it's not the physician's responsibility. That's the instrument is not so good. So total body PET-CT really help us do a lot of things. So finally, through this study, we got the conclusion that total body PET was more sensitive than conventional PET-CT in detecting that small or that's the low uptake lesions. So that's the advantage. We use it in clinical, really solve a lot of problems. High sensitivity really brings us so many benefits. For example, this is a young lady that suffered from Takayasu and disease. And the patient underwent that the FDG PET imaging. And after 2 hours injection, we performed the first examinations. We confirmed that small lesions in the aortic wall here is not so clearly. And 5 hours later, we performed the scan again, and we see it very clearly. So for this kind of the disease, that long time that the delay imaging, we can catch more lesions. So for this kind of the disease, we regularly use the long time delay imaging. 5 hours, that's the routine work for us. This is another very interesting case. This is a patient suffered from the lymphoma, performed the PET examinations for the therapy response. And we use the conventional PET-CT scanner. We just, after 1 hour injection, we get this imaging. And then after we got this imaging, when we read this imaging, we found that the diagnosis that the information is not enough. So that's the 12 hours later after the injection, we call this the patient back, and then perform that the lower extremity, the imaging. From this imaging, everyone can see that the imaging quality is meet the request for the diagnosis. And we really catch so many small lesions here. Even without the total body PET, it's impossible. So it's really helped us solve a lot of problems. And fast scan is another advantages. So we performed a study, try to find the ultra-fast scan, and finally we got that even using that the 30 seconds scan, we can catch most of those lesions. Although it's very fast, but we all know that in clinical practice, we pay special attention that's for the imaging quality. So we just want to get high imaging quality to solve the problem. And this is a case. It tells us that fast scan is really help us get the high imaging quality because this patient cannot lay on the bed for a long time. Just after 1 minute scan, the patient will not accept the examination. And during the 1 minute, we also get the high imaging quality and meet the diagnostic request. And this is very exciting. And another one probably is another very interesting case. During the acquisition, the patient motioned. And we all know that after the motion, we cannot get a high imaging quality. But right now, we can reconstruct the imaging with that the different time duration and a series of those imaging compared with each other. We can catch the key points and give the final accurate diagnosis. The dynamic scan could really help us do a lot of things. And this is one of our study, just evaluate 1/10 of the PET scan could get the same biodistribution with that the regular dose. We have performed this study with the two groups. One is using that the regular dose, and one is the 1/10. From this MIP imaging, we can see that almost the same biodistribution. And this is the TAC curve. We can find that except that the peak value is lower in the 1/10 group. Other, that's the shape of the curve almost the same. So from this study, we found that the biodistribution of the 1/10 dose FDG PET imaging, we can get the same results. That's the health volunteer. And then we performed in the patient. That's one group of patient. First day, we just give the patient 1/10 dose. And the second day, we give the patient half dose. From this imaging, we can see that 1/10 dose and the half-10 dose, the biodistribution almost the same. That's the results the same with that the health volunteers. But how about the lesions? From these lesions, we can get that the biodistribution when using that the low 1/10 and the half dose almost the same. We can see that the TAC curve, that the shape almost the same. So we got this solid evidence. We used the 1/10 dose in clinical practice. This is a patient suffered from the lung cancer. We use that the 1/10 dose. After the examination, we got the imaging. We can see these lesions here. That's very clearly. Not only for this the original lesion here, but also for this the metastatic lymph nodes here. So everything we can get it. In our department, we use the 1/10 dose as one of our regular work. Sometimes for the children, that the 1-dose dose have so many advantages. So sometimes we use it for the children. And in clinical practice, that multi-tracer used together, that's very popular in clinical works. This is the patient with the night. And at the first time, we're using that the 1/10 the FDG PET. And the second day, we performed that the delta Tate imaging. That's using that 1/3 dose. And we can compare it with each other and can evaluate that the disease. After the therapy, we performed that the study again. That's the 1/10 FDG imaging and the 1/3 that the delta Tate imaging. For this kind of the imaging, sometimes we think that not only will reduce the radiation, but also probably that's a very important factor that sometimes that the generator have not enough illusion. So low dose help us solve this problem. During the past years, we have published more than 30 papers focused on the total body PET. And in last year, we led a collaboration of 11 hospitals in China to publish the world's first expert consensus on the uEXPLORER total body PET CT. If you are interested for that, you can search in the PubMed. So in summary, that total body PET make PET CT examination easier. And at the same time, the total body PET expands the PET, the clinical applications. And at the same time, the imaging quality is much better than the conventional. And during this time study, we really found that total body dynamic scan has the potential clinical application values. Although it always takes time, but I think it's worth to do that. That's what I introduced today. Thank you for your attention. And welcome to China. Welcome to visit our department. Thank you.
Thank you, Dr. Shi. Now I'm delighted to introduce Dr. Harshad Kulkarni, Chief Medical Advisor at BAMF Health. Dr. Kulkarni is a nuclear medicine physician with an emphasis on theranostics applications, and he is the primary driver for clinical trials performed at BAMF Health, which is the first theranostics clinic in the United States utilizing the uEXPLORER system. Over the years, he has co-authored over 150 publications and has received over 6,000 citations in a variety of world-class journals and conferences, including the Journal of Nuclear Medicine and the European Journal of Nuclear Medicine and Molecular Imaging. Please join me in welcoming Dr. Kulkarni.
Good morning, ladies and gentlemen, and thank you so much for the kind introduction. So I'm going to be filling the big shoes of Dr. Badawi and Dr. Shi, talking about the enormous potential of the total body PET CT and concentrate on the theranostics applications. So just a brief introduction. Theranostics can be seen as a lock and a key principle, where you have the target, which can be targeted by radioligands which bind specifically to that particular target, and the radionuclide, depending on what radionuclide you use. The entire radioligand can be used for both diagnosis as well as treatment. So basically, with the theranostic application, you're doing the total body PET CT using that particular tracer, the same ligand what you're going to be using for the treatment later on. So BAMF Health is a global company which is focused on evolving the industry to make the best radiopharmaceuticals both available and affordable to patients as soon as possible. And our aim is to achieve AI-enabled intelligence-based precision medicine through both molecular imaging and molecular targeted radiation therapy. So just a very brief introduction. So it's a 60,000 square foot occupancy of this particular building on the first, second, and the seventh floors. We have the global headquarters, the molecular imaging clinic, therapy clinic, and the radiopharmacy. The reason why I'm emphasizing on this is just because we have, as Edwin mentioned, we have a dedicated theranostics clinic on which the emphasis, is really to have the production of the facility, production capabilities, as well as imaging and treatment going from the start to finish. So we have the United Imaging Explorer PET CT and PET MR within few feet of distance, as well as the digital SPEC CT from Stargate. Just a very brief view of our molecular imaging clinic. So the PET CT or PET imaging has really evolved over time. We had the gallium-67 images in 1990s, and then gradually through parametric F18 FDG PET CT in 2019, now we have come a long way with the total body uEXPLORER. So I'm going to be not really go through these slides. I mean, the experts here on the podium, but you've already heard from them the tremendous capabilities of delayed imaging as well as dynamic imaging and low dose or low acquisition times. So one of the really emphasis is in cancer patients. What we are importantly concentrating upon is these patients are generally in a poor condition and not able to lie down on the scanner for a long time because of pain. So as the gentleman already mentioned, we can go down to as low as 10-second acquisition. And if you see very closely at 30 seconds, you are able to see all the lesions, and that really does not make any difference on the clinical management. So gallium-68 PSMA-11 PET-CT with prostate cancer has tremendous applications for the management, early diagnosis, treatment, and also follow-up and response monitoring in prostate cancer. And the key here is to diagnose the prostate cancer at the earliest of stages so that you can treat them, and as in this particular patient who had a sustained complete remission of the disease. Also, with the PSA, it's actually quite a reliable marker, but in advanced stages of prostate cancer, where the prostate cancer metastases do not produce PSA, that's when you have to rely on the PET-CT imaging. So I'm just going to go through a few cases which will highlight the role of the total body PET-CT. So this 76-year-old patient with prostate adenocarcinoma, Gleason 9, he had a pretreatment PSA of 35.4, and he had 2 cycles of PSMA-targeted radioligand therapy in Germany, and had a subsequent biochemical improvement of his disease with the last PSA of 1.92. Now, we have to find out what is the extent of the disease, and as you can see, you're able to actually not only see the smallest of the lesions, but you're also able to pinpoint the bone metastasis in which the PSMA expression is less, and that correlates with sclerosis on the CT images. And this patient had a stable disease, and that's why we could keep him on a follow-up. A Gleason 8 prostate cancer patient who had a definitive radiation therapy to the prostate, and then he was lost to follow-up. He had proceeded with homeopathic remedies and eventually then presented with a left-sided hydronephrosis because of the extensive lymphadenopathy as well as biochemical progression of the disease. And with the total body PSMA-11 PET-CT, you're able to see with a very high resolution, the smallest of lung metastasis, and with a very high PSMA expression. So this particular gentleman then did undergo 3 cycles of PSMA radioligand therapy because he was not eligible for a chemotherapy, as well as had stopped treatment with the second-line hormone therapy because of intolerance. And these were the post-therapy images. What he had, there was an improvement in the PSA, but you can just see on the post-therapeutic lutetium-177 images that there is still quite a lot of uptake in his lungs. So we did a follow-up gallium PSMA-11 total body PET-CT, which clearly shows a excellent response to the treatment, and then you can keep the patient on a sustained follow-up. A Gleason 7 prostate cancer patient who presented to us with a biochemical progression of the disease, and he had already had 1 cycle of a targeted PSMA radioligand therapy. So he came to us for a follow-up, and you can see a lymph node over there with a central necrosis, but also you can see a small para-aortic lymph node metastasis, which actually potentially changes the management of the disease. This particular 93-year-old gentleman, not to go through the entire history, but he had a metastatic castration-resistant prostate cancer and was not eligible for a chemotherapy, being, because of his additional conditions. And with the total body PET CT, you can see the extensive metastasis right down to the lower part of the thigh. And on the right side, what you are seeing is the post-therapeutic image with the star guide, which shows really the whole principle of theranostics. We treat what we see, and we see what we treat. Another interesting case of an advanced metastatic castration-resistant prostate cancer with metastasis in the lymph node and bones. And you can see, just because of the total body imaging, you can pinpoint the metastasis right down to the metatarsals. And the reason, Dr. Shi spoke about, and Dr. Badawi spoke about the role in arthritis. So we had here an actual evidence that when the patient underwent a lutetium PSMA radioligand therapy and we did the post-therapy scans, there was a PSMA uptake, a sustained PSMA uptake in those metastases, confirming that those are metastases and not arthritis. So just because you have the total body PET CT, you can see quite an extensive disease in his lower limbs, which can really have an impact on the quality of life. Another interesting case here, you can see back reconstruction of the images down to 30 seconds. So we did a study in which we did the back reconstruction down to 30 seconds of 50 patients, and we clinically, two blinded independent radiologists and nuclear medicine physicians, they reported on the findings of the PET CT at 30 seconds and 5 minutes. And the results were there was no significant clinical impact on the management based upon those reports. So even though the 30-second acquisition misses a few metastases, that does not have a clinical impact on the management. So really for patients who might be in a poor general condition because of the extensive metastasis and difficulty in lying down, you can really bring down the time of acquisition, and of course, you can adjust the dose to be injected. In neuroendocrine tumors, which is also where the role of theranostics has been well established well before prostate cancer. So this was a particular study in which the acquisition was done from 1 minute to 10 minutes, again showing that even at 1 minute you have a good target to background ratio. So we had a patient with a small intestinal neuroendocrine tumor grade 1 with lymph node metastasis, and he was ongoing. He had an ongoing somatostatin analog therapy, which is the standard of care for neuroendocrine tumors. On the left side, this was an external gallium-68 DOTA-TATE PET CT from August 2022. And on the right side is with a uEXPLORER in which the patient was imaged recently, showing a progression of the disease. And you can really see the smallest of lymph node metastases can be picked up with the Explorer without any problem. I'm not going to go into detail on these applications where the experts have already spoken about, but this really again shows you the value of the total body PET CT, in which you have the entire body encompassed, and having a tracer like F18 FDG or the novel tracers, you're able to actually examine the entire body, and that's really impactful. So Takayu's arthritis, Dr. Shi already spoke about. Then this is another interesting case in which a patient presenting with colon cancer and liver metastasis, but you can see varicosities in the left-sided dorsalis pedis, which can be picked up. Another interesting application was also mentioned over here is myocardial perfusion. And the reason I'm mentioning it, on the left side, you can see with the conventional SPECT CT, where there is a global ischemia. So when you have 3-vessel disease or triple vessel disease, you do not see a significant difference on the technetium sesame B scans or tetraphosphine scans. But on the right side is a PET using O15 water, in which, because of the blood flow images, you are able to pick that up. What is also very interesting is with the oxygen 15 water, you can do the scanning of the entire body, and so you can pick up, as was already mentioned, cerebrovascular diseases and peripheral vascular diseases, amongst many others. A very important application, atherosclerosis is clearly one of the biggest killers, is the imaging using PET, in which you can use sodium fluoride for the calcium scoring. So I would like to summarize saying that total body PET-CT is a fast, sensitive, high-resolution, total body precision radiomolecular imaging and has a significant impact on the disease management. In oncology, there's a clear evidence, initial staging, early and highly sensitive detection of recurrence, confirmation of the volume of the metastatic disease and biochemical persistence, and to select patients for a targeted radiomolecular therapy. So it's an integral part of theranostics as well as evaluation of therapy response. And just to briefly mention, dynamic imaging has a role in drug development, pharmacokinetic studies, and vascular indications. Tailored imaging is possible with a high target to background ratio with a pre-therapeutic dosimetry and has umpteen number of other indications. Thank you very much for your attention.
Thank you, Dr. Kulkarni. Last but not least, I'm happy to introduce Dr. Zhi Yang, Director of the Department of Nuclear Medicine at Peking University Cancer Hospital. Dr. Yang primarily focuses on radiopharmaceutical research, and he is one of the very first uEXPLORER users in the world. He works closely with both academia and industry to bring molecular imaging into the development, evaluation, and monitoring of new radiopharmaceuticals. Through Dr. Yang's leadership, Peking University Cancer Hospital has become one of the leading clinical and research cancer centers in China. And with that, please welcome Dr. Yang.
Thank you, introduction. Good morning, everybody. I'd like to, I'm great honor to have a chance to be here. Today, my presentation will be total body PET-CT, booster the clinical translation of new molecular probes. In here, I will be first talk about why we did the total body PET-CT. Since 2019, the total body PET-CT scanner have been installed in many centers in China and the US. It can be utilized for the development, validation, and clinical translation of new tracers, find the basic clinical characteristics of new drugs, discover the optimal imaging time window, also pharmacological studies, etc. In my institution, Peking University Cancer Hospital, we have already formed the entire pipeline of radiopharmaceutical discovery and development. We believe with the aid of the total body PET-CT, the development process could be accelerated. We are lucky to be among the first users of the total body uEXPLORER PET-CT. The scanner had been installed on the June 2nd, 2022. We were amazed at the superb performance demonstrated at the acceptance test. We are thrilled to have the advanced scanner. Besides the clinical routine for uEXPLORER PET-CT, we have also conducted clinical trials of an array of new tracers. These tracers range from small molecules, peptide, antibody, nanobody, and monoclonal antibody. They cover a broad spectrum of targets, including HER2, PD-L1, PD-L2, Claudin 18.2, Nectin-4, et al. Various poison nuclides such as carbon-11, F18, copper-64, gallium-68, zirconium-89, and iodine-124. Here, I would like to share some research highlights involving these tracers. First, I'll introduce PET tracer targeting HER2. Using uEXPLORER, we have studied the difference of the random clearance profiles of the NOTA kiliter and the RISCA kiliter, and the accelerated random clearance of the tracer with the RISCA kiliters was observed. The next, we have already prepared anti-CES nanobody gallium-68 HNI-01 colorectal cancer patients were recruited and the dynamic imaging was conducted. Preliminary data shows that the uptake of the tracers correlates well with histopathology results. Thus, the PET imaging with our CA tracers may play a role in the patient selection, prognosis, and treatment monitoring for cancer patients. This slide shows the PD-L1 nanobody gallium-68 APN-09. The tracer was tested in lung cancer patients. Patients receiving the immunotherapy were recruited, and their PD-L1 expression were visualized through the gallium-68 APN-09. Preliminary data show that patients with a higher uptake of the tracer have a better prognosis compared to those with low uptake. This is Claudin 18.2 is highly expressed in stomach, pancreatic, breast, and lung cancer, accounting for 1/3 of the tumors. It has good specificity and has become an emerging target for anti-tumor therapeutics. The clinical data of an antibody of Claudin 18.2 shows that with stage 2 gastric cancer, it can significantly prolong the median survival and reduce the risk of death by 49%. In our research, both the nanobody and the antibody was labeled with gallium-68 and the Claudin-89, respectively. Preliminary clinical results have shown great promise in application. Recently, the Nectin-4 target has been recognized as a promising drug target with desirable tumor-specific expression, which is especially important in urothelial carcinoma. Accordingly, we have prepared the gallium-68 and 18H peptide. Multiple time point images were acquired with this tracer, and the bone metastases as well as the adrenal gland metastases were clearly delineated, showing a higher contrast compared to FDG. The immunohistochemistry confirmed the expression of Nectin-4 in lesions visualized. Gallium-68 gray tracer is level probe in my lab, targeting glycine secreted by activated T cells. It can reflect the effector function of cytotoxic T cells. This method can be used for early efficiency prediction of multiple immunotherapies, including CAR-T therapy. Patients with high CD18 expression can be treated with immunotherapy. Patients with low CD8 expression are recommended to receive immunoactivation and other treatment such as surgery. At the same time, we did the PSMA PET tracer for PSMA-BCH and P13.7 for clinical trial. It has a different structure of the PSMA-BCH P13.7. It has a different kinetical parents in organs. This is dynamic imaging study of PSMA-BCH and P13.7. They are both mainly excluded in the urine tract, but P13.7 has faster expression spread. In addition, both tracers were free of radio concentration urine shadows in the blood up to 300 seconds after injection. A series of studies have shown that early imaging of PSMA PET helps to detect local recurrent lesions. Thus, dynamic imaging provides a theoretic explanation for the studies. To compare the difference between delta Tate and the JR11, dynamic images were also acquired as the antigenist JR11 doesn't have the internalization behavior like the antigest delta Tate. Thus, the kinetic behavior of JR11 follows a resemble to compounds model whereas delta Tate is reserved. With this information, we can also determine the optimal imaging windows for these tracers. One of promised applications is analysis of blood clearance. With total 13 tracers has the blood clearance assessment from this list. In summary, we have the full body coverage and the full body ultra-high sensitivity reflect the new potential of PET-CT. Systemic pharmacological studies tracking the dynamic process of drugs through the entire body. Total body PET-CT realized high resolution, high sensitivity, ultra-fast, and ultra-long delay imaging. Although we have only been operating the uEXPLORER total PET-CT for 1 year, we have already felt the impact of new technology on PET tracer. Development with the suitable physical performance and the imaging capability, we believe that the new scanner may transform the burden of clinical evaluation of radiopharmaceuticals and provide whole new dimensions in the understanding of pharmaceuticals. Potential role of total body PET in drug evaluation pipeline, it was mainly applied in first-in-human study, safety evaluation study, and pharmacology study. Thanks for your attention. That's it.
Thank you, Dr. Yang. And with that, thank you very much for attending. And since we've run out of time, we kindly ask you to reach out to our guest speakers after this event if you have any questions. We hope to see you again at our booth today at 11 a.m. to witness the launch of our new flagship whole-body PET-CT system, the UMI Panorama, as well as our next satellite symposium tomorrow at 11:30 a.m., where our first UMI Panorama users will share with you about how they are using the system to break barriers in every direction. Thank you again and have a great meeting.